Thank you, Dr. Ferenc, and good evening, everybody. So when we talk of shorter DAPT, there are various thought processes which go in. So we move away from this, and let's talk of EBC main. When we talk of left main, and we talk of 70% of the left mains have bigger diameter, more than 4.5, and more than 80% of the left main disease involves bifurcation. There could be unique challenges, including wider bifurcation angle, larger side branches, and additional calcification. Limited evidence, however, exists in form of best treatment strategy for left main lesions. This is a case, the patient was getting repeated short-lived rest angina, and every time there were these huge ST depressions in all the anterior leads, and also, very importantly, an ST elevation in AVR. It used to settle down the moment the pain went away. So we were suspecting very difficult lesions, and this is how it was. Left main was totally occluded, completely supported from the right side. You can see a huge right coronary artery, which was quite good, and it was supplying the entire left system. You can see the septal branches, the LAD, and the circumflex all fed from the right coronary artery. Obviously, this was a very emergency situation, and patient was sent for a bypass surgery. The story is a little old, but maybe in these days we can put this kind of patient for an angioplasty. The EBC bifurcation club left main coronary stent.
Dr. Hiermath, I'm sorry to disturb you. There was, I don't know, your slide is very huge, and we see only part of your slide. I don't know. At least in my laptop, it's only a part to see from your slide.
I don't know how to.
But, we are able to see completely.
Okay, that's maybe in my laptop. Okay, I'm sorry.
Yes,
Go ahead.
We are able to see it completely. Yeah.
Yes, yes.
So I continue, or I'm sorry, Dr. Ferenc.
Yeah. Please continue now.
Please continue.
Yeah, the study, the EBC main, there were some important consideration. Many trials have shown a lack of benefit associated with systemic two-stent strategies. Like you can see here in the bar, the Nordic one stent versus two stents, the benefit coming from one stent. The EBC2 also had similar inference on bifurcation, and outcomes may be worse with systematic dual stent strategy. So dual stent strategy as a bailout looks reasonable, but planned dual stent was probably not as effective as single stent strategy. So when we talk of left main, we know that left main is a different animal. It has a wider angle between LAD and circumflex. Neither of these vessels can be called as a side branch. Both could be big. There are more calcification and fibrosis, greater need for vessel preparation before we take the stent in. Also, there is ample evidence from non-randomized trials showing worse outcomes with two stents technique. So this disparity, single stent or two stent, continues. And however, randomized data from Dr. Xiao Ling Chen supports decay crush. That means obviously two stents for left main bifurcation. So this actually big left main analysis. We know in left main the highest elastic content of coronary artery, and that's why we need to use a sustained radial force to prevent recoil. So a location which is very risky, and we also need long duration inflation. This was a case where lesion was only in the distal portion of the left main, and I was evaluation of the proximal LAD as well as proximal LCX was quite satisfactory. So we ended up putting only a focal stent, only in the distality of the left main. However, things have changed, the thinking has changed quite a bit, and these days we would probably never do that. This was many years back when we did this. So we have this young individual. At age 28, he had the first infarct from the right coronary artery, which was fixed. He moved from 28 to 42 when he had lesions in the LAD and aneurysm in the proximal LAD. So this portion of the LAD after the origin of diagonal was fixed with drug stent, while the proximal portion was fixed with covered stent, which is not a medicated stent. He moved from 42 to 49 when he had issues at the back end of the two stents. So he had to have another procedure where we had to put two medicated stents to cover the narrowed segments. This was actually a catheter-induced dissection. So this gentleman had an inferior MI, and we had to fix his right coronary artery. So at age 28, the RCA had a stent. At age 42, we had advanced disease. So this portion of LAD was fixed with Zion's stent, and the proximal aneurysm was used with a covered stent. Both worked well for another 7 years, and there was a critical narrowing in the back end of the two stents, ostial LAD, ostial circumflex. So he went another procedure at age 49. So I would feel that progression of disease, especially when it is picked up very early in life, is always almost a rule. So this was another case where there was a dissection related to the guide catheter, which was extending from left main into LAD and left main into circumflex. So this was when we were preparing a workshop in another town. So I was actually taking a class, and I had to leave everything, make sure that the wires were in the correct lumen on an IVUS, and quickly do an SKS. So SKS is probably a quickest stent delivery, and it salvaged the situation. This was another case which was done about 250 miles from our hospital, where the operator placed 8mm short length stent in the mid portion of a very long LAD and another stent in the ostial LAD. So two stents, one in the left main and one in the ostial LAD. However, this patient had a dissection, and this patient was transferred something like 250 kilometers. And we fixed this stent first, this area, dissected area first, then address the side branch, because circumflex circulation is a big circulation. Then while doing this, we had a dissection related to guide catheter deostium. Stent number 5 was placed, and the side branch to stent 4 was also stented. So overall, we ended up with 4 extra stents to salvage the situation. Things started like this patient with this kind of angioplasty results. So when we talk of EBC main, we are talking of European bifurcation club and stenting, whether it should be a single stent versus dual stenting for the left main. So 31 centers, 11 countries, 467 patients. And the Medtronic stent was used. They were randomized. The study hypothesis was stepwise layered provisional strategy versus systematic dual stent strategy. So in the upper one, the plan was provisionally to end with a single stent and then have a usual comparison. So in this particular study,
Dr. Hiermath, we have problems to
2 stents
connect with you. Hello?
You can't hear me?
Yeah, it's really some interruptions. Because of time, maybe Dr. Hiermath, maybe you just present us the final results of the study, and then we have maybe 1-2 minutes to discuss the data.
Basically, this study was to check if provisional approach to the side branch stenting can be done, or you need to do a systematic 2-stent strategy. The syntax score overall was not too bad, about 22. A radial approach was done in about 70% odd cases. Then acute coronary syndrome was about between 33 and 40% cases of the arms.